Good afternoon and welcome to today's session. My name is Kelsey Goforth and I'm DWDC's Director of Programs. Today I'm joined by my colleagues Melissa Mueller and Amanda Coventry-Barrage. Before we begin today, I want to acknowledge that while we are meeting virtually, the land that Dying with Dignity Canada is on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Indigenous, Inuit, and Métis peoples. We want to welcome you today to our first session of Dying with Dignity Canada's Learning Centre. Through this series, we aim to provide comprehensive information on several issues related to medical assistance in dying in Canada. By attending these 5 sessions over the next month, you should gain a thorough understanding of barriers to access for those trying to access MAID, as well as some common areas of confusion surrounding MAID. If you're interested in attending the upcoming webinars over the next month, we will put the link in the chat so you can register for those sessions as well. Before I welcome our speakers today, I'd like to go over a few housekeeping items. Everyone on the call is muted. However, there will be opportunities to send in your questions. To do so, please type your question into the question bar on the Zoom side panel and we'll read it out for you at the end. Please try to keep your questions as clear and concise as possible. We're going to try to get to as many of those questions as we can today, but unfortunately we might not get to everybody. So if you do have something outstanding or you have a question that's personal in nature, please email us at support@dyingwithdignity.ca and we'll follow up with you there. We'll also be sending a post-webinar survey. It will pop up on your screen when we wrap up today, and that will give you an opportunity to share your feedback on how today went. Also to note, this webinar is being recorded, so there's no need to worry about taking notes. You're welcome to rewatch again at a later time if you like. Now we're going to introduce our speakers today. We have with us Kevin Reel. Kevin is a senior ethicist with the Health Ethics Alliance at Sunnybrook Health Sciences Centre. He earned his degree in occupational therapy at the University of Toronto before pursuing accreditation in teaching in higher education, healthcare ethics, and a Master's of Science in medical ethics in the United Kingdom. A registered occupational therapist, Kevin is an assistant professor and graduate faculty member in the Department of Occupational Science and Occupational Therapy at the University of Toronto. He is a member of one of the many working groups contributing to the development of a national curriculum on MAID, led by the Canadian Association of MAID Assessors and Providers, CAMAP, and funded by Health Canada. He has also served on the boards of a number of national groups on bioethics, including the Community Ethics Network. Welcome, Kevin. And joining us, we have Dr. Marc Gabel. Marc is a retired physician and MAID assessor with multiple specialties and years of experience practicing in Canada, the United States, and Malaysia. A Cornell and Downstate Medical Center graduate, Dr. Gabel also served in the U.S. Air Force as an active duty medical officer and returned to the U.S. to pursue accreditations in pediatrics, a master's in public health on tropical medicine, as well as held a private practice in general medicine and psychotherapy in Canada. With over 20 years of membership at the College of Physicians and Surgeons of Ontario, Dr. Gabel served as president of the CPSO from 2013 to 2014 and chaired the Professional Obligations and Human Rights Policy Group and was also a member of the MAID Policy Group. A devoted husband of 48 years and grandfather to 6, Dr. Gabel now enjoys his retirement and provides consultation services to health professionals. Thank you both for joining us this afternoon. I'm going to turn it over to Melissa to get us started.
Thank you.
Thank you, Kelsey. Welcome. Just a quick disclaimer for everyone on the call today. As you can tell, both of our speakers are from the province of Ontario. And so we will try to speak to the general principles related to effective referrals on a national standpoint, but there may be some information that is specific to Ontario. So I just wanted to let the viewers know that. So yeah, thank you so much to the both of you for joining today. We're going to get started right into the Q&A, and the first question is for Kevin. So Kevin, just to get us started, can you tell us what an effective referral is?
Happily, thanks for asking me. and in this context of assisted dying, I think that the idea of effective referral has defaulted in many ways to the situation where there is somebody who is on conscience grounds objecting or abstaining from engaging in supporting a patient to explore or fulfill their request for assisted dying. So what the college did when it came up with this term effective referral is they created the mechanism by which a patient would get access to the information that they wish to have about a service from which that practitioner is abstaining or objecting. You might see a sort of similar sense of the requirement to refer in a situation where the request for assisted dying would be seen to be outside the scope of competence or the scope of practice of a practitioner, but it's actually the referral bit is always within the scope. It's very easy in our current situation to make those referrals that are effective. And the CPSO describes them as a positive action that ensures that the patient's connected in a timely manner to somebody who can help them pursue their wishes. The whole point of it is to ensure access to care and respect for patient autonomy. And it doesn't ever mean that the patient's going to receive whatever treatment, nor does it signal that the clinician who is objecting or abstaining endorses or supports the treatment. So that's sort of some of the limitations on what one ought to take from the fact of somebody having made an effective referral. And I'll leave it there.
Perfect. Just a quick follow-up question to that as well. Who is required to make an effective referral? Is it just physicians or is it all healthcare providers that can do this?
Yeah, so of course the CPSO policy, which is the one that's most frequently discussed, applies to the people they regulate, which are physicians and surgeons. But then other regulatory colleges, they have similar expectations they place on their practitioners. So the College of Nurses in Ontario, at least, has a requirement that somebody who doesn't provide medical assistance in dying must refer the patient who requests this to another NP or physician who does provide this service. So they don't necessarily seem to use the same term effective referral, but they're making it clear. And this is in keeping often with their other kind of practice standards that they have. And they also require that there is a transfer of care and that the person work with their employer to make sure that there's an appropriate alternative care provider. And it's often very much couched in the idea that this person or their request should not be abandoned in any way. The other thing that they require is that the practitioner does not directly convey or express to the patient their disagreement in any way with the decision to explore assisted dying. And in addition, because the other profession that's very involved are pharmacy, the Ontario College of Pharmacists states explicitly that in circumstances where a pharmacy professional declines to assist inmate on the basis of a conscientious objection, they must provide the patient with an effective referral to a non-objecting alternate provider where the patient can receive the desired services in a timely manner. Of course, these things also apply to situations where something like abortion is the topic. In all these cases, the colleges also specify certain other things about how the communication must be sensitive and respectful with the patient. And then other colleges that regulate other professions also have requirements for ensuring that patients receive the services that they are requesting. So, and it doesn't necessarily speak to MAID specifically, but it does talk about objections on conscience grounds. So my regulatory college, the College of OT, also says that if you're objecting to something on conscience grounds, like medical assistance in dying, then you have to do so transparently while also meeting all the other responsibilities and accountabilities of the standards of practice that the college has produced. So they again refer it back to the full standards that are expected. So it's not just physicians and NPs, it's other people who might end up becoming involved in some way, shape, or form.
Great, thank you so much. The next two questions are for you, Marc. So the first question I wanted to ask you was, what are the fundamental elements of an effective referral?
I could best explain it by imagining that I was this doctor who was approached by one of my patients, and I happened to have religious or conscientious objections to MAID or some other process that's legal and available. And I think the first thing a physician, and what we expected at the college, was that the physician would explain to the patient sympathetically and understanding that they are not able to participate on that basis, but that they would be there for the patient in any case, and that they will make an effective referral to an accepting agency, physician or nurse practitioner, and would follow through, and who would be the contact in their office to do that. The requirement is not that the physician himself or herself make the referral, but that the effective referral occurs with their knowledge by anyone else in the office who they've designated to do so, and that they will as well follow up to be sure that the referral occurred. And most importantly, there is no refusal of continuity of care. The patient is still the patient of that physician and is expected to follow through on that basis. And I think that pretty well covers, with the last one being the most important part, that if you make a request and it's not something the physician is able to be part of, your care still continues.
Perfect. Thank you. Another question that I have, and Kevin, you briefly mentioned it when you were speaking, is transfer of care. So is an effective referral the same as a transfer of care, or are they different? And if so, how?
I think what I covered in the last statement was the same on that there is no change in the care. You're still that doctor's patient and remain so unless you and he or she agree to a change. The referral is specifically for an assessment and evaluation of your request around MAID. I should just say, though, hopefully, in working with any physician, be they objecting or not, that there's been discussion about other forms of care as well, based on the stage of your illness and disease. There is, I think, more and more in this day and age, an expectation that we will go through end-of-life care, as well as all the other kind of care that has been given over the time that you were related to a physician.
I'll also just add that that expectation that there's continuity of care exists in the other professional standards as well. So you would make the effective referral for everything to do with the MAID request, but you would continue to provide care within your role that is unrelated to things to do with MAID. So that exists there too for others.
Great, thank you. The next question, so this is more about the policies and experiences with effective referrals. So Kevin, when considering an effective referral through a bioethical lens, what are some of the considerations involved?
So I would say, in my opinion, like at the heart of this, effective referrals are about trying to manage the difference of ethical perspective on a particular issue, where that issue straddles both the context of professional duties that a clinician has and patient needs that a patient has. So the difference in these perspectives relates really to the way that the individuals involved understand the fundamental ethical principles that are at play in these relationships and care provision. situations, so that things like respect for autonomy, beneficence, or the idea of doing good, and non-maleficence, the idea of not doing harm, the idea of having practice that's based on a principle of patient-centered care, and even in some ways the idea of reciprocity, which is about give and take, in the sense that health professionals are entrusted with a lot of privilege in our systems, and that those privileges carry responsibilities too. And in this context, what's happening in the kind of ethical debate around effective referrals, it's the extent to which somebody can impose requirements on your professional practice, and the idea that professionals are, by virtue of their role, that is a role that is sort of in some ways blessed by society, and blessed again by the fact that society gives these professions the right to self-regulation. We regulate ourselves in each of these professions through our regulatory colleges. So what is the extent to which that regulatory college, to which we all have to belong in order to be licensed, can actually place expectations and limitations on the role. And then in the legal side of this debate, that's framed in terms of the Charter of Rights and Freedoms, and particularly the freedom of conscience and religion, and whether or not the requirement to make an effective referral for a service that I feel morally out of sync with, morally misaligns, or doesn't align with my own morals and ethics, is it okay to basically require me as a criterion of my ongoing regulation and license to practice that I have to make these effective referrals? And the answer to that from the court seems to be that, as it says very clearly in the Charter of Rights and Freedoms, these freedoms are not absolute, and that where defensible limits can be placed on some of these freedoms, that's acceptable in a free and just society. So in this context, it's what's been argued as the less significant impingement on your rights around freedom of conscience allows for the more significant freedom of rights around the determination of self. That would be the possibility of pursuing information and potentially assessment for and provision of assisted dying. So the court ultimately found that effective referral requirements in the policy that the CPSO had written was facilitating equitable access for patients to healthcare services, and was sufficiently pressing and substantial to warrant the overriding of the individual physician rights to have conscience freedoms. So that's the kind of ongoing debate, and it went then through the courts and came out ultimately looking favorably upon the way that the CPSO had approached it.
Certainly. Thank you. Marc, I know that you worked on the CPSO's policy on effective referrals, and this is a great segue. Could you share with us what that experience was like and the considerations involved and what the policy ended up including? Just sharing your experience of being involved with that.
Yeah, I would start out by saying the policy was designed prior to MAID becoming legal in Canada. We were more concerned at that point with other areas, mostly around abortion, birth control, and some other more esoteric areas. And so when the committee got together, there was a sense that the college had mostly come down on the side of what does it look like from a physician's point of view. And the committee this time wanted to look at it from both the physician and a patient point of view. Life had evolved beyond just thinking about the rights and care of physicians. So we looked at the Ontario human rights decisions of the Commission so as to give us a framework. We wanted a policy that obviously we felt fit the Charter of Rights and Freedoms, and looked at things such as patient autonomy, non-discrimination, as Kevin mentioned, professional integrity, and collaboration as well between various physicians and their specialties. And the result was coming up with the term of good faith effective referral. We felt that that balanced the needs of both the patients and of physicians. There was, shall we say, a great degree of controversy around this. I think we received over 10,000 letters, mostly form letters from various organizations and individuals against the policy. We also received others, obviously, in favor of same. We commissioned our own survey so as to get a sense beyond what was being sent to us as letters of what the population of Ontario thought. And we came up with figures of over 90% in support of this conceptual framework. And while there was a degree of sometimes, to be very honest, of threats and some very negative publicity, I know I went through some things in various newspapers accusing me of some reasonably negative situations. Some ethicists called me a ethical cleanser at one point in the National Post. There were it was fraught with some controversy, but we felt we were on the right track. And as Kevin mentioned, the two levels of court when it was challenged by the Christian Society of Doctors and Dentists on both levels agreed that our compromise, you might say, matched the Charter's needs to cover when you have conflicting rights, to find the balance that best took care of the situation. And we were satisfied that we had designed a process that could go forward to cover other things as when MAID arrived as well on the scene.
Great, thank you so much for that. A question for you, Kevin, is how would a patient be impacted in the absence of an effective referral policy?
Yeah, this is something that I'll answer from my limited experience. So I work in a hospital primarily, and I'm not therefore as familiar with the way that things might unfold in a community context. And also I'm in an Ontario hospital where our arrangements provincially for care coordination and for referrals for assisted dying are not coordinated as centrally as they are in other provinces. So some provinces have a single central referral system, which makes it even that much easier. But when an effective referral is not provided to somebody who's inquiring or requesting assisted dying, you can imagine the outcomes will vary widely depending on the patient, even depending on the manner of communication with that patient, and then the context of the patient themselves. So they may live in an area where there aren't ready providers in the geographic region. Their condition may be such that it's a kind of pressing request because they could lose capacity quite soon. Or they might just be in increasing amounts of discomfort. They can have other complicating factors as well. One of the things that is always at risk of happening is that depending on how the provider's position is communicated, they might end up with a perception of disapproval from that provider. And in some cases, if this provider is, say, perhaps their primary care physician, then it's the one person you go to for all of your healthcare. And then you're introducing into this therapeutic relationship, this kind of set of tensions around this is what I asked about, and you dismissed it or told me that I shouldn't be asking about it, or however it was potentially communicated. And a lot of those professional documents that frame how this is supposed to happen do talk about that idea that the provider is not supposed to convey any sense of disagreement or judgment about what the patient's requesting. So the other obvious impact is that there's going to be a delay in accessing the required clinicians who will do the required assessments in order to find out if the person is eligible in the first place. So you're left wondering if you're eligible at all. And then you need to make connection with those who can then progress your request if you do choose to pursue it. And that includes the physician or nurse practitioners who do the assessments, and then ultimately the one who agrees to do the provision. But it also often includes the pharmacists who would dispense the required substances or medications in that case. So there may also be delays that result in the patient or the person who's requesting losing the option altogether, because they might then lose capacity and may not be able to demonstrate the capacity at the point where they have to for the assessments, the request, and either the waiver or the final provision. So there's a number of different things that can happen, and those are just a few of them. They're the sort of the more obvious ones, I would guess.
If I might add,
Yeah, go ahead.
some of the problems can be around hospitals and hospital policy. So you have certain of the hospitals in the province in Ontario I can speak to that will not allow provision within the hospital. Many of those hospitals, including some of the Catholic hospitals, will allow assessments to occur. They will refer for assessment. There are other places that might not even allow assessment to occur within their facilities. This is a problem which has not been resolved. I know I have done assessments in places where the provision of MAID cannot occur. So the patient has to be moved, which sometimes is straightforward. But again, considering the condition of that some people are in and the pain and suffering, it is a difficult and painful thing to have to move, and also to find where to move to. And I would mention that there is this place called Maid House in Toronto, which is one of the places that is a neutral place that people can be moved to, but it still, on the whole, is problematic in my mind.
Yeah, certainly forced transfers is a whole other webinar that we're actually going to be doing next week that does talk about the barriers that people face. And yeah, certainly Maid House is just one that we know of, right? It's a new space, but yeah, if you're not in the Ontario or GTA and finding a space for Maid, it can be challenging. Marc, the next question is for you. So what should a patient do if they do not receive an effective referral from their primary care provider?
That's a kind of difficult question, because on a practical basis, there you are somewhat dependent in your condition at the moment on the practitioner you're working with, who has taken care of you for a long time. And very honestly, it is a difficult process to say, I'm going to report you as not following the effective referral policy, or to a pharmacist who you've been using for all your medications for the last decade, to say, I'm going to report you to the College of Pharmacists. So I think it puts the patient in an extremely difficult practical situation. The you might say bureaucratic fashion is, yes, you can make a complaint to a college that so-and-so did not provide the effective referral required. But honestly, again, I think most people in the province don't know about this policy, don't understand it. And sure, you know, if I put myself in a condition, I know what to do at that point. I'm aware, but it is not true of a great number of people in the province who are dependent upon the people who care for them. So aside from saying that you can make this complaint, I don't know that the situation can be more than our continuing educating physicians, nurse practitioners, pharmacists, other health professionals in their obligation and in following their professional needs to be compassionate, caring, and helpful to the patients they deal with, especially at this point in their lives where life has changed beyond what most people can comprehend. So I'm sorry, I can't give do this and something will happen. There are just too many factors involved, and we can only hope that compassion and empathy win out. And some pressures occur as new graduates move forward and take over various scenes.
It's as clear as mud, giving an effective referral or when someone doesn't receive one. The other question is for you, Kevin. What are some of the current challenges that impact the process of effective referrals, if any?
I think that Marc alluded to it when you mentioned, Marc, the whole institution opt-outs that continue to happen. So those can be hospitals or hospices. And a lot of those are on the grounds of being a faith-based institution. But with hospices, they're not always faith-based. They opt out on the grounds that they don't see assisted dying as part of the palliative care realm, which they support, which is clearly debatable because a lot of palliative care practitioners actually do assess for and provide MAID. So those big whole institution opt-outs are, I think, one of the difficult things. I think, as you also alluded to, Marc, they may be slowly improving over time, because I can remember when some of the faith-based institutions would not allow even assessments to happen on site. And when I worked in community care at the time, knowing that there were some requests that were happening that meant there was a kind of surreptitious connection with an assessor, and the assessment was going to happen adjacent to the hospital on a park bench, sometimes in a churchyard, which seemed kind of very, very bizarre, and wasn't at all a solution for a lot of the patients who were very, very ill and who couldn't go outside and meet with a physician and nurse practitioner on a park bench. But I think that is slowly improving, and the fact that a lot of hospitals will now, those faith-based places will now allow assessments to take place, at least in the walls of the institution, is a step forward. And I can't talk about this without noting that it's really not clear, and it's quite contested, that an institution has charter rights to opt out on these bases, and it's debatable what the language means around that or not. I can also say that I was made privy to some forthcoming research that's to be published soon that does suggest that over time some of these things are improving, as you alluded to again, Marc, that there are newer practitioners coming into the world that are more at ease with these sorts of things. I know here we have recently expanded the number of MAID assessors and providers we have, so that's been quite good. And I think one of the things that can help immensely is that where the institution brings in its own effective referral mechanisms. So whether that's a faith-based institution that says, okay, when we get these requests, this is exactly how they're dealt with, so they're dealt with quite quickly. I recall dealing with requests that were stalled for over a week because the then policy required that the MRP, the most responsible provider, usually the doctor, had to try to find a willing other institution to have a transfer of care entirely to transfer the patient all the way to another institution, which just never happened for MAID. It was against policy that you would receive people solely for MAID. So that just created big delays. But if there's a truly effective policy that allows for the referral to happen within the institution, potentially going extra institution, that's one of the things that makes it much, much easier. And for us, I know that we have a simple way within the institution for somebody to just send on minimal details of a patient who's requesting, and then we can follow it up as the coordinators. But some of the worst things, I think, are where I know of a number of hospices and even long-term care homes that will actually, in their intake process, aim to make it clear that they don't want MAID happening on their premises. And so they kind of try to avoid even ever having to make effective referrals for their residents or their patients by saying up front, if you're thinking about MAID, don't come here, which is quite annoying, because then they may end up, going there not really thinking about MAID, but then MAID may become the thing that they want for very good reasons. And it just becomes very problematic. The other thing that I know I have heard has happened, and it's impossible to know the details without actually reading the chart notes, but sometimes, MAID requests are dismissed outright. The person is told outright that they're ineligible for some reason, which on the face of it doesn't make sense. It's not a valid reason in the reports I've heard. So, one report was that somebody might have actually tried to end their own life because they didn't know that MAID was an option. And somebody in the emerge department just says, oh, well, you shouldn't have done that because now you're not eligible for MAID for 6 months or for 12 months or something, which just, bears no resemblance to anything in the law. So that's a kind of an ignorance problem, or it could be an almost sort of willful obfuscation problem, that they're coming up with a reason why you don't have the right to make this request, so I don't have to make an effective referral. And then I think too, as you can understand, there's no real way to track when effective referrals aren't made. So we have this very good kind of monitoring microscope on MAID practices through the federal reporting, which is, okay, it's as good as it is. It probably would be lovely if it were more involved, but then that creates a heck of a lot more work for people. But there's no real way to track how many effective referrals are not made, how many people don't get the option or the timely option of pursuing an assessment for MAID, because it really is only it's incumbent on that patient, as you said, Mark, to step forward and make that complaint somehow. So, we just don't know the extent of the problem, which is a bit of a difficulty to have to manage.
I have been maybe lucky or glad that I've not run into many of those issues within the faith-based hospitals that I've been requested to make an assessment at. What I do know is in those hospitals, the physicians who are on staff were not allowed to make assessments, so that if I wanted a psychiatrist to help me out as far as being sure the patient had full ability to consent, I could not get a staff psychiatrist at the hospital. The ethicist said they were not allowed. We would have to find an outside. So little complications of, you might almost call it bureaucracy, that can make things difficult even in the best of circumstances. But hopefully, maybe I'm an optimist at heart that these things are changing slowly but surely. And as the populace gets a better understanding of their rights, I think the insistence on that can make a big difference as well. So I think moving forward with support, hopefully the problem will decrease in its intensity.
Yeah, certainly there's shared so many barriers that people are facing right now. And I think it goes back to, education and awareness of, maid eligibility and being able to have those doctors, provide those referrals or have the knowledge. And it's MAID is still so new in Canada, right? There's still so much that people need to learn about MAID. And yeah, I'm a bit of an optimist too with you, Marc, and hoping that, there's more access for those to have the conversations about MAID at least, right? And be informed. So we're going to go into a few of the audience questions that we have. We do have quite a bit, and we do have some time, which is really good. So the first question that I wanted to ask, actually, it goes back to the CPSO policy and about timely referrals. So what does timely mean in this scenario with an effective referral?
I don't think you can put a number on it. What I think, if you have a patient who is, if I can put it colloquially, at death's door, a timely referral is rapid. It's today. And I have had requests of that kind, where can you see the patient this afternoon? There are others where there may be time for discussion about the referral. All in all, MAID should, in my mind, be seen within the context of end-of-life care, which includes palliative care, includes understanding of your needs and your social as well as medical needs. And based on the condition and the timing, I think that one should match the situation. It's as simple as that. And I think in most areas of at least Ontario, there are available assessors and providers. Obviously, in certain areas of the north, and sometimes even in some of the urban areas, there may just be fewer physicians available, especially as some of the requests can become more complicated, especially what we can call the second stream. Those who do not have reasonable foreseeable deaths requires way more time, and so that we need more providers and more assessors to help that out.
Certainly, thank you. For someone who's requesting MAID, and let's say in the province of Ontario, there's the Care Coordination Service. So is providing a phone number to care coordination considered a sufficient effective referral for someone requesting MAID?
You want to try that one?
Sure. You go ahead, Marc, because I think this CPSO.
I would defer to you on this one to start with.
I think it's taken by some to mean that, and one can argue that it does actually, it could actually do the trick, in the sense that the people at the MAID Care Coordination Service will then connect you with providers locally. It's just, I'm not quite sure how ready their list is for every area of the province. And it's also just, it's a difficult thing, because I may be asking for information about MAID. I may not be asking for an assessment. I may not need an assessor. I might just need, a conversation with a coordinator in a hospital to give me more information. So that's, it also just depends on whether the patient who receives that phone number is readily at liberty and able to actually make the phone call, and potentially wait on hold, as I have done a couple of times, because they go through very, very busy periods. Other periods, they're not busy in the same way, and you might be answered quite quickly. It's a referral. I wouldn't say that it's the most effective referral, because it doesn't necessarily leave you feeling as sort of well satisfied as it would do if you had somebody who was there to talk to you personally, which is possible in most cases.
Yeah, I agree, Kevin. The use of a care coordination service, which is a wonderful service, and the people who work it are just as fantastic on keeping track of people who call them. But we have needs far beyond just that kind of referral. And there are an amazing number of people who may have real difficulty making that phone call based on language, based on knowledge, based on how sick they are, based on their support around them, people who are either supportive or not even being supportive. So the difficulty arises, and in the original, now I'm going back many years, in the original policy, we did not include a referral service. It was that you had to refer to an accepting health practitioner, which would in this case would be a nurse practitioner or a physician. I believe that was added after my time at the CPSO as part of the, I don't know, accommodation, you might say. I'm not in favor of it being a requirement. I think the care coordination services would be best even used by physicians. I need someone, I need some help. But it has become a de facto possibility for patients to call. And they do the best they can, which I have found in my experience to be pretty amazingly comprehensive.
Thank you. May have another difficult question for you. So this is more of a MAID navigation question. So if a track 2 patient's family doctor refuses to make a referral to a specialist when the MAID assessor has requested this referral, is that family doctor required to make an effective referral to see that specialist? Because we know in many track 2 cases, or in some, that there are referrals required, and the MAID assessor may not always be the one to provide that referral, and it has to come from the patient's family doctor. But if the patient's family doctor is objecting to MAID, are they then required to make a referral to a specialist or someone else to make that referral?
My thought, and obviously I hear what Kevin has to say from an ethics point of view, is that my understanding in track 2 is that the 2 assessors who are involved in this are the ones who need, if neither one of them have the expertise in that situation, to arrange for not necessarily a consult, but information that will allow them to be fully conversant with the situation that they're confronting. It doesn't require of necessity a formal referral and an assessment by another specialist. I can call up a specialist and say, I need information about so-and-so to help me fully understand this disease process. And if I feel competent at that point to have known what is available, what could happen, that is sufficient to itself. So I don't think the problem as stated is a real one. I don't think the physician who objects on a conscientious basis has to now also make a referral to another specialist and get involved when that is purely for informational purposes for the assessors in order for them to fully understand the disease process they're dealing with.
Yeah. No, I concur with you, Mark. I think it's somewhat disappointing that a family physician would be digging their heels in that way. But the assessor, one of the assessors ought to have expertise in the condition, and if they don't, the one who is ultimately the provider has to ensure that they do consult with somebody who has expertise. And it's not, as you point out, it's not required that it be somebody who's deemed a specialist, but somebody who has expertise, which is a different thing. And that assessor who becomes the provider can avail themselves of other ways to get that sort of a consult happening. And again, it isn't about that that third practitioner having to do an assessment. It's about imparting the details that they have, their familiarity with the condition, to the assessors to be able to then be assured that their assessment is being made with those kind of expert knowledge details involved in the way that they're interpreting the person's situation.
Great, thank you. Another question that we have is, how many times can a patient ask for an effective referral? Let's say to their family doctor.
Good question. I suppose that if they've asked for an effective referral and they've been referred, I mean, if they haven't been referred, they can repeatedly ask until the referral happens, I suppose. But if they've been referred and subsequently assessed and found ineligible, they may request another assessment. They could again do that through the first practitioner who was not participating and therefore made the effective referral. They'd probably be better to do it through the MAID assessor, who is probably better connected, or through another avenue if they're wanting to pursue further assessments. There's no legal limit on how often you can be asking a particular clinician for a referral for a MAID assessment. It just kind of might come down to a little bit of civility in terms of, you know, that this person has done it for you once. Can you find through the same means you were connected the first time, your own way through to it the second time? But they can still ask.
Great. So this question is not MAID specific. So aside from conscientious objection, what are other reasons for doctors to not provide an effective referral? So an example, someone says, if a family doctor refuses to provide a referral to a patient because they feel they are equipped enough to provide care, although the patient is requesting to see a specialist, how would this be handled?
I don't think that in a doctor-patient relationship, if I'm the patient and I say I want to be referred to an orthopedic physician or whatever, and my family physician sees no purpose to that, I don't think the family physician is required to make that kind of referral. We have said that in situations that have nothing to do with conscience or with religious objections, it is a typical interaction between a doctor and a patient. And the doctor, as I have often done, can explain to my patient why I don't think that this is the moment for that kind of referral. The patient can go elsewhere, obviously, but this is part of a give and take of any long-term physician relationship. And I mean, if a patient walks into a walk-in clinic and requests a referral, they don't necessarily have to make that referral. It's based on clinical judgment again. We're talking here about things that are with a conscience or religious objection to the situation. I think that if a patient was to come to me and request a referral for MAID assessment, part of what my discussion would be, since I don't have an objection on those usual bases, would be what other things are happening here, to discuss the entire end of life care, which may include that referral for the care, for the assessment. And if the patient wants that assessment and it is there as an obvious issue, in other words, the patient is on a trajectory toward death, then you make the referral. But I think part of a good doctor-patient assessment is all the other forms of end-of-life care, that this should be a continuum. MAID is part and parcel of end of life in Canada. but it's not the end all and be all, for sure.
Thank you. Going back, there's a couple questions related to forced transfer. So the first one is, we talked about, facilities that don't allow for MAID. Is there, to your knowledge, a published list of hospitals that do allow MAID, or is it just, similar to going to the hospice, kind of doing your research ahead of time if possible?
I think that varies across the country, and I don't know of any published lists anywhere in any province. I just know that in some provinces, the province has simply mandated that every institution has to provide this, whereas it hasn't happened in all provinces. So in my experience in Ontario, it's really just a matter of, I think many people assume that the faith-based institutions, certainly the Catholic institutions, would not allow provision on site. And I think some of them at least now do allow assessment on site. But that pretty much every other public hospital does manage, in whatever way they do it, requests for assisted dying assessments and often provision for assisted dying. And then with hospices, again, it's an individual thing. I think you have to find out from individual hospices, and oftentimes the people who are coordinating the admission process to the hospice will know, or will be able to ask at least, which hospice would be open to the idea of somebody coming in and subsequently having MAID there, or not. And hopefully over time, those that are willing to have that happen on their premises will continue to increase in number.
Mm-hmm. So a bit of a follow-up to that, someone has gone through the assessments at the hospital, but they can't have the procedure in the medical facility. Could the patient go home to have this provision? And I'll pass that one to you, Kevin.
I mean, there's nothing to stop them legally from going home. It happens in homes almost half the time that I'm aware of, in Ontario at least. Homes being like private individual homes and apartments, and also long-term care homes and retirement homes. The trouble is that not everybody can actually just very easily transfer out of the hospital to go home, because they may be incredibly unwell. They could be very frail and very readily injured by the idea of a transfer. And many people don't want to have this at home. There's various reasons why some people really want it at home and other people don't want it at home at all. There was an illusion at some point that, when somebody died in the house, it was something that had to be reported when the house was subsequently sold, which is not the case. But it was certainly not the case when it's an ordinary kind of death, like a MAID death or a death from other natural causes. But some people just don't want to have it at home. And it also requires, you might not have access up the stairs if you live in an upper flat. You might not have the kind of facilities at home that would allow you to toilet and to transfer and to lie in bed comfortably. It may not be possible to set up all the arrangements so that home care can come in, if that's going to be arranged as well. That said, some people might actually go home very quickly and just have it done at home, which then requires some kind of negotiation with the people who are the assessors and providers, because they may have to be somebody who comes in from the community to assess in hospital, but they have to have privileges in most of those circumstances. So they have to be allowed by the institution to come in and practice in that hospital to do the assessment, to then follow that person home. We were, I think, in the past, prior to COVID, doing a couple, not very many, but occasional provisions where the patient was an inpatient and went home and was followed by one of our practitioners for the provision at home. That stopped with COVID for obvious reasons around infection prevention and control. But there is that option. It just isn't an option for everybody, especially when somebody is rapidly proceeding toward death. or simply has reasons why they don't want this to happen at home if they have young kids at home, or their partner is going to remain living at home, or other family, and they don't want to have had the death there, which is not an uncommon perspective among a lot of people.
There was a time prior to COVID where hospitals some secular hospitals would admit patients for the purpose of provision of MAID. With the inability to find a bed and infection control, among other reasons, has pretty well stopped as a possibility. I would again mention that at least there is in Toronto, MAID House. Hopefully there will be other places like that formed around the country. I know there's interest in it. And hopefully Dying with Dignity will be part of helping people set up those type of facilities.
Absolutely. So we have a couple more questions, and just a little bit of time left. And forgive me if we've already, touched on this a bit. This question is, there is a requirement in the CPSO policy that the referral is to a clinician or agency that is available and accessible. When there are long wait times at care coordination services, is this requirement still being met? The available and accessible component.
Well, I think it's practical. Well, you wanted to say something, Kevin?
No, I would say, yes, it's not like if it's referred to another clinician in the hospital, they're available, but maybe not until the next day or the day after. So, we have those kind of very reasonable practical delays in the hospital context where we're very happily progressing and processing an effective referral. If you have to call, in our case in Ontario, the MAID Care Coordination Service and wait on the line for however long, I don't think that's necessarily a huge barrier. It's a reasonable wait time, as far as I know. I hear varying stories about how long those waits are, from people saying they got through right away, to people saying they had to wait for. I did once wait about 30 minutes, I think, or 40 minutes, but then it's thereafter they may not actually see, once they connect with the nurse coordinators, they may not actually be seen by their assessor in the community for some days, or even once I heard weeks, but then soon after that I heard there was really no delay. So it's really a kind of hit and miss thing. It varies tremendously around the country. So if you're not in an urban area like ours, we're very fortunate. We have a number of community providers that are within the hospital's catchment area. So we know that the people that we're encountering here who want to go home and be assessed at home, they'll be seen relatively swiftly, because we are fairly well serviced with providers at the moment. In other more far-flung regions, that's not always the case. And that's just a kind of an operational problem in a country that has the kind of geography that we have, which I've always thought is one of the reasons why the government was astute enough to include nurse practitioners in this practice, because it just offers a little bit more flexibility in terms of who can do it, especially in those typically less well-served areas.
Mark, did you have anything to add?
Only that to add that this is true of any form of medical referral. We are tight as far as doctors are concerned, and you may be referred to a cardiologist, you may be referred to many other type of specialties, and there is a waiting period. I am amazed at how well the care coordination service will get to you. But again, I know when I've been requested, when I was practicing to see a patient, I might have to work out a schedule that fits in. And with MAID, it became, with COVID, it became even more difficult, and which patients could be done via this type of online situation and how to get to someone who may be an hour and a half or 2 hours away, I might have to give it 2 or 3 days before I could find the moments and the time to do that. Like with everything else, we do the best we can on that. And as Kevin has said, in certain places, it's very difficult because there are so few providers, not just of MAID, but of any other service as well.
Kind of tying into that, into my next question, what happens when you do live in a small community with only one doctor and they've referred a doctor that's far away? Is virtual an option for assessments, or are people able to travel and meet the assessor halfway or in a location? Are those things possible?
It is possible to do a virtual assessment. Along with COVID and my own situations, I did many assessments on a virtual basis. This doesn't apply to everyone. I was lucky in that I could always find a relative who could do the setup if there was technical issues as well. And a lot of time was sometimes spent on that. But yes, virtual is a distinct possibility, obviously not for provision, but for the assessments themselves. Yes, that's available. It's paid for by the province, and can be done with many people that way. And that just is another way of making sure that people get the service and the compassion and needs that they have be met.
Perfect, thank you. So I just have 2 other questions for you both. So the first question is, how well do you think effective referrals are working in Canada? And is there room for improvement? I'll start with,
there's always room for improvement.
Yeah.
I honestly can't answer that because I don't know how well it's working. I have not personally heard of people who found it impossible to find to be referred. But again, we got a negative here. How do you know how many people didn't get connected properly? There's no way that I know that. I don't know if there's been complaints to the college since I've not been at the college. And I don't know that there's been any publication by the college of how many complaints they've received in this area. So it's very difficult to answer that. I don't know if you have anything more to add to that, Kevin.
Sadly, no, it is one of those things that like you just can't know what you don't know. So it would be only really discernible through the reports to the college. You get anecdotal stories, but the anecdotal stories only give you a kind of a very inaccurate glimpse of what's going on. So we really just don't know. I think it's just the more time goes on, the more provisions that happen. There's an increasing number of people out there in the world who know someone who either had MAID or know someone who had MAID. So there's going to be a kind of word of mouth benefit that will go on, where there will be people be able to just describe to each other how it worked in a case that they knew about. And I think that might be something that will be in everybody's favor eventually.
Absolutely. So I have one more question for the both of you. The final question. So we've talked a lot today, and the question is, if our audience leaves the webinar today with only one takeaway, what do you want that takeaway to be?
I would always have more to say than one takeaway. My thought is that one, that you have the rights to be assessed, and that's an assessment, not necessarily an approval. You have a right to discuss that. And if you're approved, you have the right to not proceed as you decide to. Sometimes just being assessed and know where you stand may be enough to let you wait a bit longer. that assessing palliative care does not in any way stop you from later on assessing MAID care as well. That it is possible to explore all those options. They are not mutually exclusive. So that to assess palliative care, some people are worried, well, will that stop me from being able to ever get MAID if it turns out to be that direction? And no, it does not. So my takeaway is that you do have rights to have a continuous process that will work best for you.
Thank you. And Kevin?
I think my takeaway would simply be to just, you also have the right to keep asking. So we keep asking questions about how to get what you want, whether it's just information, whether it's information that then leads to an assessment, and keep asking more people. So if you're in hospital, there's lots of people to ask, and there should, in most hospitals, be a very simple, effective referral system. A lot of hospitals have their own in-house MAID care coordination service, somebody who's designated to do it. And when you're in the community, just again, keep asking. And ultimately, if you need to, you can go to Dying with Dignity's website and you'll likely find the connection you need within your own province to access what is typically there that is organized provincially or territorially to make access as easy as possible.
Great. Well, thank you so much for joining us this afternoon. I'm going to share a few messages from the audience already that found this webinar very helpful. One said, thank you so much to Kevin and Dr. Gabel for offering their time and expertise. And another message, thank you for your compassion and insightful information on this topic. And so I'm sure so many have learned a lot. I know I have, and we really value your expertise on effective referrals. And so to close off, webinars like this one and all of our other compassionate services are provided free of charge to Canadians navigating end of life, their loved ones, and their healthcare providers. And to enable us to continue providing these services, please consider if you'd like to make a charitable donation. And we have put the link in the chat in case anyone would like to donate. And we are continuing with our May Learning Series. We have 2 webinars next week. Tuesday, May 16th will be on forced transfers, and Wednesday, May 17th, we will be speaking with MAID clinicians on the impacts of MAID and the next steps. And then the following week on May 23rd, we'll be sitting down to debunk some of the most common myths and misconceptions about MAID. And then to wrap up, on May 30th, we'll be hosting a webinar on advance requests and the waiver of final consent. And so to register for these webinars, or if you'd like to share the link with a friend, if you already are registered, we have also included that link in the chat for you as well. And again, thank you so much to Kevin and Marc for joining us this afternoon. I hope you all have a great afternoon, both our presenters and our audience members. Thank you so much and have a great day.
Thank you all.
Thank you. Thank you, Melissa.
Thank you.
Thank you, Kevin.